So, stigma and bias impacts care for patients from the beginning of their interaction with healthcare all the way to the end. And when I say beginning, I mean even their desire to reach out and interact with the healthcare community, right? We know that sometimes patients who are obese may feel intimidated immediately, even about making those appointments. Right. So, number one, how we are treating patients when they're with us goes home with them. And then they decide, like, oh, last time I went, I wasn't treated well. I didn't feel comfortable. The space wasn't made for me. And so it may even start there from, their desire to reach out and even make those appointments. Implicit biases, we know, really impact how we treat patients on a moment to moment, person to person experience, right? And so patients who are obese have reported feeling seen as less than, right? Getting less eye contact from their physician, being touched less, just the hello, hi, how are you? Put your hand on the shoulder type of interaction. Those type of implicit biases that people hold about people with obesity come out in how we interact with people and how we speak about people. What are those implicit biases? Well, we've had data that shows med students feel that people who are obese are lazy, or they may not be as prone to follow through with their health care. Um, Nursing has noted that, they may be having more difficulty with these patients, so caring for them can be harder or annoying, or, it might be disgusting to care for someone who has obesity and has a little bit more needs. And so those implicit biases, how we feel about patients, and I don't want to leave physicians out. I'll get into the physician part soon. How I feel about patients comes out in that interaction with them. And then it goes into medical decision making. People who, specifically women who are obese, get less pelvic exams. What is that decision making process that goes into deciding to do a pelvic exam? Does a physician implicitly think, oh, this is going to be difficult? Oh, we have to get her up on the bed. She might need some help to get up there. This might not be pleasant. So I'll forego that test, right? And so it goes all the way into how we make our decision-making process for caring for patients with obesity. Uh, and that really needs to change clearly because we want people to feel comfortable accessing the healthcare. But also, on top of that, we really want people to feel like they can have confidence that they will be treated well. And those implicit biases, the ways that we treat people, leads into that lack of confidence. Patients with obesity have reported feeling less confident about the care that they're receiving. That, oh, I didn't get that pelvic exam despite my concern. Medications weren't titrated up for my concern for pain. I'm not being listened to. And so there's that lack of confidence that people have in the healthcare that they're getting because of the biases and how we're treating our patients. Like I said, we have to start from the beginning. When we are addressing biases in healthcare, I want us to think about every aspect of what the patient is interacting with, including the built environment, right? Is there a space that is large enough, comfortable enough? Are gowns going to fit correctly, right? An ill-fitting gown that doesn't cover someone can lead to them feeling embarrassed, right? The built environment, number one, we need to think about how patients are interacting with that environment. But then let's get back to people-centered language. Let's get back to viewing the patient individually and saying, this is the problem this patient has, and how am I going to give my all to this patient and this problem, right? It's not, Mrs. Jones is obese. It's a patient with obesity, right? And understanding how that does, play into their healthcare, but not that that dis excuse me, not that their obesity excludes them from healthcare, right? So the same things that you're doing, cancer screenings, we have seen people with obesity get less cancer screenings that are age appropriate. Sticking to those guidelines, asking questions about symptoms, really trying to be aware about what you're feeling and how you're interacting and what you're bringing to the table, right? And then be really aware of your language, be really aware of your exam and how you're treating people. And this goes is not just for physicians. I want to include all of our staff that are caring for patients. I work mainly in hospitals, or I should say only in hospitals. And I want this to also include our nursing staff and our therapy staff. It's not, hey, I need an extra body to move this patient and yelling that out loud. You can step outside and say, I need to move Mrs. Jones in a few moments. I will need some assistance, and then go in as a team and help move that patient in a way that is respectful, right? And so identifying in yourself, number one, what your implicit biases are, and then using patient-centered language or people-centered language. And then also listen to symptoms, listen to people's experiences, and work the problem up as you would that's medically appropriate. Whether or not you think, oh, this part is going to be difficult, it may be hard for them to access a radiologic exam, something like that. Still, if that's what it calls for, that's what should be done. Go ahead, reach out, get those things done and ordered for patients.